Hello everybody, welcome to Menopause Taylor, and welcome to the last video in the long unit on osteoporosis. Can you believe that including this video, it's a total of 35 videos? I sure hope you've watched all the osteoporosis videos that came before this one, because this one is going to face you with the cold, hard reality of the deficiencies in the care of women with deficient bone. Understanding all the material in the videos that have preceded this one will enable you to see just how deficient it is. But it will also empower you to avoid the pitfalls that befall you at every turn. If you watch this one video, you will realize that it's up to you to make sure you do what's best for your bone, because there is nothing in place with your best interests in mind. So I'll organize this presentation by first stating the fact that contributes to osteoporosis, and then stating the deficiency in care, and then stating what would be in your best interest to correct the deficiency. Okay, so the first and most basic fact contributing to this deficiency is that women do not receive any education at all on osteoporosis. Heck, they don't even receive any education at all on the entire topic of menopause. So the average woman has no idea that menopause puts her at high risk of osteoporosis. Instead of associating menopause with hot flashes, we should be associating it with bone loss. You learned that the same oversight is present with regard to heart attack. This education I'm giving you is the only one of its kind. Other than what you get from me, it simply doesn't exist. That's entirely unacceptable. All women should know that menopause and bone are directly associated with one another. This deficiency in education is the most basic deficiency in the care of women with deficient bone. We could correct the deficiency if all women got this education on menopause. My dream is for all women to get this education in their 20s or 30s. The second contributing factor is the simple equation that I taught you at the very beginning of the osteoporosis unit. Estrogen loss equals bone loss. The problem is that while women do talk about shrinking with age, they do not attribute it directly to estrogen loss. It's like they skip over the most important aspect of shrinking with age, estrogen loss. Because nobody wants to admit that estrogen is beneficial, they ignore its effect on your bones. This deficiency in attributing estrogen loss as the very cause of bone loss is contributing directly to deficiencies in the care of women with deficient bone. And we could correct the deficiency by teaching women that estrogen loss is the very cause of bone loss, period. Just put slogans everywhere that say estrogen loss equals bone loss. The third factor contributing to this situation is ignorance of the true incidence of osteoporosis. It affects over 25% of women. It's not a rare occurrence, and that's only the incidence of frank osteoporosis. If we take osteopenia into account, it's over 75% of women. So here you have a disease that affects the vast majority of women, yet women are unaware of its incidence and prevalence. And being unaware of the magnitude of the problem is one of the deficiencies in the care of women with deficient bone. And the easy way to correct this deficiency is to inform all women that osteoporosis is one of their greatest risks. The fourth factor contributing to the deficiency is the rate of bone loss in the first 5 years of postmenopause. Women are always shocked to learn that they lose 2% of their bone every year in just the first 5 years of postmenopause. This is the very time when most women are completely ignorant, still in denial, or under the delusion that they can just tough it out and everything will be okay. They assume that there's nothing more to menopause than the obvious symptoms. They have no idea that the greatest and most rapid effect is on their bones. This oversight of the rate of bone loss is a huge deficiency in the care of women with deficient bone, and we can correct the deficiency by informing and preparing women in advance for that significant bone loss that occurs in the early years of postmenopause. Fifth on our list of deficiencies in the care of women with deficient bone is the fact that bone loss produces no symptoms at all. But most women don't know that. You have no warning that it's happening. You just lose bone silently for years and years. Silent diseases are always the most shocking. They creep up on you long before you know they're there. So you have to know that it's a silent disease. And the fact that the symptoms are deficient and that women have no idea that they're deficient is a huge deficiency in the care of women with deficient bone. Once again, correcting the deficiency requires informing women of the fact that there are no symptoms of bone loss. The sixth deficiency pertains to the fragility fractures that result as a consequence of bone loss. They occur out of the blue, as they say, and they result from things that you would never consider to be fracture-worthy. There's just not enough bone present, so you fracture your spine, hip, or wrist doing normal, basic things that are not traumatic. Some women can't even tell you how they sustained a fracture. This makes it very difficult to avoid fractures. The fact that fragility fractures due to deficient bone are so unavoidable is a huge deficiency in the care of women with deficient bone. And to correct the deficiency, women should receive an education about the nature of fragility fractures. The seventh factor contributing to the deficiency is that women are unaware that the prognosis for a fragility fracture is like no other kind of fracture. Instead of healing and going your merry way, it cripples you so that you cannot even do the simplest of things. It leaves huge numbers of women unable to live independently. Having no idea that a fragility fracture from osteoporosis could end your life as you know it is a huge deficiency in the care of women with deficient bone. And correcting the deficiency would require women to learn to avoid osteoporosis and the fragility fractures it causes at all costs. The eighth deficiency contributing to osteoporosis is that most women do not know the list of risk factors for osteoporosis. They have no idea that it encompasses so many different things. And if you don't know the risk factors, it's unlikely that you will have the opportunity to do whatever you can to change the ones over which you have total control. Just knowing what puts you at risk for osteoporosis is very powerful. So ignorance about the risk factors is a huge deficiency in the care of women with deficient bone, and correcting the deficiency requires educating women about all of them. Gee, do you realize that so far, every one of the solutions for the deficiencies consists of education? Deficiency number 9 is the fact that too few women get bone density tests early enough to detect bone loss early. This is mostly due to guidelines and insurance protocols. They all designate age 65 as the age for your first bone density test, and that's nearly a guarantee that you will already have significant bone loss. But even if you request a bone density test earlier than age 65, you are likely to get pushback from your doctor and your insurance company. I consider this one of the biggest deficiencies in the care of women with deficient bone. I mean, for goodness sake, if you've got a disease that occurs automatically upon loss of estrogen, and if all women eventually lose their estrogen, and if there are no symptoms of bone loss, wouldn't it make sense to enable all women to get bone density tests early and often once they lose their estrogen? The 10th deficiency is that all too often, even when a woman does get a bone density test, the physician focuses on the wrong result and misinforms her that her bone density is normal. Instead of focusing on the T-score, which compares your bone density to the 30-year-old woman, they focus on the Z-score, which compares it to a woman of your own age and ethnicity. Well, if all women lose bone as they age, there is nothing normal about a bone density test that is normal for women of your own age and ethnicity. All that does is lower the standard, and lowering the standard means that you do not get treated for your bone loss. I consider this to be another of the biggest deficiencies in the care of women with deficient bone. All we have to do to correct the deficiency is to do away with the Z-score altogether. It's worthless. The 11th deficiency pertains to the risk assessment tools for osteoporosis. They are supposed to detect women who are at risk of osteoporosis so that they can receive treatment earlier than they would otherwise. But they are designed by the same folks who created the goofy guidelines and the Z-score. They do not include all the risk factors for osteoporosis, and they don't even require a bone density test. So instead of identifying at-risk women early, before they have osteoporosis, they instead diagnose osteoporosis late or later than all the other means I've discussed. So the risk assessment tools are terribly deficient in providing care to women with deficient bone. And this deficiency could be corrected if risk assessment included all of the risk factors, as well as a mandatory early bone density test, and they served to diagnose early bone loss. Deficiency number 12 is that women who have premature menopause are at especially high risk of osteoporosis, but they're not informed about it in advance. They do not realize that losing mass, amounts of bone, early in life has devastating consequences. They are doomed to osteoporosis and multiple fractures if they do not understand the importance of preventing it. This deficiency is entirely inexcusable. It contributes greatly to the deficiencies in care of women with deficient bone, and all it would take to correct the deficiency is include some kind of protection from osteoporosis as part of all instances of premature menopause. Deficiency number 13 is that none of the dietary, lifestyle, vitamin, mineral, or herbal options for osteoporosis is capable of anything but prevention of bone loss from normal bone. However, both laypersons and medical professionals commonly assume that they are capable of fixing osteoporosis or capable of intervention of osteopenia. They aren't. This becomes a situation in which even if you have an education on osteoporosis, and even if you've gotten a bone density test early, you can still fail in your efforts to prevent or replace bone loss simply because you misinterpreted the capabilities of these options. And to make matters worse, it's very common for the medical profession to recommend these options, and only these options, for frank osteoporosis. Misinterpreting and misusing the options for managing osteoporosis greatly contributes to the deficiencies in the care of women with deficient bone. And once again, correction of the deficiency requires keeping each management option in its proper lane for prevention or intervention or fixing. The 14th deficiency is the mere fact that although estrogen loss is the very reason for bone loss, nobody wants to promote estrogen replacement as the logical solution for preventing or treating bone loss. This is all due to fear. Irrational fear, but fear nonetheless. Ignoring how central estrogen is to the prevention and treatment of osteoporosis is like failing to see the elephant in the room. Because everyone is so afraid of estrogen, everything else about osteoporosis is completely distorted. Because no one wants to admit that estrogen is vital to your bones. They've changed the guidelines for diagnosing bone loss, compared your bone density to a lower standard, recommended the wrong treatments for it, and allowed women to sustain unnecessary fractures. The whole thing is just so convoluted. This fear of estrogen is the most significant and saddest deficiency in the care of women with deficient bone. Add to that the ridiculous mantra about taking the lowest dosage of estrogen for the shortest period of time, and you rob yourself of ever taking a high enough dosage to prevent bone loss at all. And when you stop taking estrogen, the bone loss occurs all over again. But despite estrogen's protective effect on your bones, every tactic is in place to make sure you don't get that protection. And oddly enough, if you correct the estrogen deficiency, you automatically prevent or correct the bone deficiency. The 15th deficiency is that although there is a smorgasbord of non-hormonal medications for bone loss, the guidelines for taking them use the same ridiculous mentality as everything else in the realm of osteoporosis. Instead of prescribing them early when you have lost very little bone, the guidelines limit them to women who have already lost so much bone that they have full-blown osteoporosis or even a fracture. How is this possible? Even though there is no fear surrounding these medications like there is with estrogen, you still can't take them until you're staring a fracture in the face. It's as if the system has done everything in its power to ensure fractures in women. The fact that there are non-hormonal medications but that you can't use them until it's really too late is another inexcusable deficiency in the care of women with deficient bone. Correcting this deficiency would be easy too. The decision as to whether or not to use one of these medications should be yours, not your insurance company's, not the guidelines. Do you see just how many levels of deficiency there are in the care of women with deficient bone? There is absolutely no reason any woman has to suffer through bone loss, fractures, and permanent disability. They are all entirely preventable. And yet, most women know none of this. This is why I educate you. You have to understand these things in order to protect yourself. You have to demand a DEXA scan. You have to demand estrogen replacement. You have to demand non-hormonal treatments, and you may have to pay for them. But think of it as buying your way out of a fracture, or 2, or 3. It will be the best money you have ever spent. As usual, I've created a chart of these deficiencies, and you can find it in the link just below the screen or at my website, which is menopausetailor.me. Here in the first column, you see all the factors, 1 through 15, that I enumerated. Next to that, in the second column, you see the current deficiency. And in the third column, you see how we can correct the deficiency. I've used pink tints for all the factors that have to do with educating women. And I've used blue tints for all the factors that are due to the current medical system. And it turns out that there are 8 that can be corrected by education alone. So if you learn all that I have to teach you, you will have the tools to demand what you want from the other 7. Just remember, no one will ever take care of you as well as you will take care of yourself. You will hear me say that again and again and again. And this education is what will enable you to know how to take care of yourself. Alrighty, ladies, we are finished with our osteoporosis unit. Whew! Next week, we'll embark on a little unit called the Neglect series. I look forward to seeing you then. Please go to menopausetailor.me to schedule consultations, and don't wait. They are very, very popular, and it takes a while to get on the schedule. I am a very busy girl. Follow me on Facebook, Twitter, and Instagram. Be sure to subscribe, and I will see you next week. Bye!